in which we are seeing first there was a deposit on the left tube which has been removed, and now if you look on the right side there is a huge cyst of around 9 centimeters which is being lifted. I mean, rather than giving incision on the most prominent part, the endometrioma is being lifted from the pelvis, and while lifting, the fluid, because of the attachment to the ovarian fossa, has been separated. The whole of the cyst has been drained, and the whole of the cyst is lifted out of the ovarian fossa. As we can see, the adhesions are being broken, and step by step the ovary is separated from the whole of the ovarian fossa where it has been stuck because of the endometriosis. Now once the cyst has been completely separated, from the ovarian fossa and the surrounding gut, I mean, we can make out an opening of the cyst, the pathological opening of the cyst in the most dominant part of the ovary. Now, once that opening is identified from where the chocolate fluid was drained, as we can see, right now we are separating the cyst from the ovarian fossa completely. Now, the whole of the ovary is lifted out of the pelvis which was stuck, and the adhesions are broken. So now we will identify that opening. All the adhesions will be cut from end to end, and now no adhesions would be left, as the adhesions have a property of forming adhesions more. So now once the opening is identified, we are going to open that that wall further to increase the size of the cyst. And we can see we are using the harmonic. There are two ports on the surgeon side and one port on the assistant side. The assistant is holding the ovary, and the surgeon is increasing the size of the opening so that the cyst wall can be easily taken out. Now you can see there can be some struggle, but if you have the knowledge of the experience makes you realize how to open the cyst. So you can see the ovarian, the cyst is being increased. Here you can identify the assistant is holding up the adhesion. The fold of adhesion is covering the ovary, which will be removed subsequently. Right now we are focusing on the opening the ovary, and then you can see the brown colored thick walled chocolate cyst peeping out of the ovary. Now we will be opening the yes. Now once the adequate incision has been given, the adequate incision in the sense that you are able to see the cyst wall completely, the assistant is holding, it will be traction and counter traction. If you are in the right plane, the bleeding will be very minimal, and it is the complete avascular plane between the cyst wall and the ovary. So here you can see how easily the cyst wall is identified, and we will remain in the avascular plane. In case some bleeder is accounted, the bipolar would be used to separate. See, the cyst wall is going off completely, and it looks like a complete pathological cyst wall which is being separated. So the whole of the cyst wall, there should be an attempt to remove. See, it is completely avascular. The pinkish part is the ovary, and the avascular part is the cyst wall. So the cyst wall is being held by the assistant, and it is being removed by as I said, by the traction, counter traction. So you can use the Kellys, and sometimes a tooth forceps is very helpful. because which is not actually very traumatic if it is held properly. And see here, not a minimum of the ovarian tissue is going with the cyst wall, and if any vascular part goes, it should be separated completely. So you can easily make out the cyst wall is getting very beautifully separated. The whole of the cyst wall is separated from the ovary. Just look at it. It just does not seem that there is any vascularity in the cyst wall. So once the whole of the cyst wall has been separated, it will be, the ovary is left. I hardly use any
We can see the cyst is completely
cautery
removed,
bipolar.
and
Minimum bipolar is needed
in this
if you are in
particular
the right
frame there was
plane.
a part of the cyst wall
Then
which was left, so there should be
the
an attempt to
ovary,
completely remove the
if you can
cyst
see,
wall so that there is no residual disease. And as far as complete, I mean, just like in oncology we say the R0, we need to achieve the R0 here also, if possible, not always. I mean, my ambition in doing endometriosis surgery is, since I have been working on endometriosis and operating most of the infertile women who present with endometriosis, the aim is, unlike the patients who present with symptomatic endometriosis, here the aim is not to do peritonectomy or removal of the implants from the peritoneum, but my aim is to maintain the tubo ovarian relationship. As a dictum, if you see the fallopian tube, as in this particular case also, the fallopian tubes are completely normal. So there is no the fimbria are found to be healthy. And then once you are through with the cyst removal, the aim should be maintenance of the tubo-ovarian relationship. If there is any kinking of the tube, it should be corrected so that the tube is straightened up. You will hardly find a hydrosalpinx, or sometimes an adhesion is covering the end of the tube, then the adhesion should be removed and the fallopian tube, as far as possible, should be preserved. So now we can see in this particular video, the ovarian cyst is almost completely separated, and the separation is usually completely, I hardly use harmonic for the removal of the cyst, which is, some people prefer to do at the base, they will use the harmonic. But if you are in the correct plane, the cyst wall will come out completely. What I particularly feel that this cyst wall is probably the invagination of the cortex, because of the collection of the endometriotic fluid on the surface of the ovary. So probably it is the invagination which forms, and the invagination is sealed off, and this endometriotic cyst is formed. So once now we have removed, we'll do a little bit of suctioning. As you have noticed, I do not use saline wash, because there are small amount of hemorrhages present. And if you do complete, if you do the coagulation, if you do the washing, all the coagulation factors will be washed off. So what I learned from my teacher, I was like, I trained in France, so they did not permit using of saline. So it is better to leave for some time, let the ovary rest, and most of the bleeders will be taken care of. There will be small clots will form, but in case you find any active bleeder, this is the right time to just do little bit of cautery, little bit of bipolar at the base, and then leave the ovary. So while one person is doing the bipolar, using two hands, the assistant is doing all the suctioning. And once it is done, then I particularly, because it's a huge surface of the ovary which is left exposed, I try to, reconstruct the ovary, not with the purpose of reconstruction, but just infolding the ovary so that the external surface, which is left exposed, is not the raw surface, but the raw surfaces are just, pulled inside. So now the next step would be, removal of um, the endometriotic cyst. Here we have done, you can see the other ovary is beautiful, normal, the fallopian tube is absolutely normal, and a little bit of, see, look at the adhesions which are there, which we had seen initially. That should be removed completely. Remove it completely from the surface, because if you leave the adhesions, they have, they are very sticky and they will form more adhesions. So better cut them at the base, right at the base where the ovary is stuck, and remove them completely. So I'm sure these methods of endometriosis surgery maintain the fertility, because we did a series analysis of our patient where we took around 13 patients with grade 3, grade 4 endometriosis, which we followed the principle of the surgery which I just discussed, and we've had 40% pregnancy rate. So, that's what I say, that do not try to remove the peritoneal deposits, or do not, if the gut is stuck on the posterior. Right now, patient is not complaining of dyspareunia. So, there is no need to separate the gut from the posterior part of the uterus, and expose that area, because as we know, endometriosis, there is a 100% chance of, there is a 90, not 100%, I'm wrong here, there is a 90% chance that re-adhesion formation would occur. So the minimum raw areas which are left, that can be, there is no need to create more raw areas. So now you can see that now you can see that now you can see that the the ovary again, the right ovary is lifted out completely. There are a few adhesions which will be cauterized on the ovarian surface, and any implants, we would cauterize them. We would, not leave, there does not seem to be any cyst. The bipolar is used to cauterize, so fulguration is the best option here. Fulgurate as much surface endometriosis as possible. So that's the purpose in this. We have done that. You can see the whole of the pelvis is cleared off. There is no need to do anything more. Any implants should be cauterized again. See, any surface endometriosis, fulgurate, 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 and the rest will be taken care by the, the bulk of the disease is decreased. Then we will shift over to the treatment of infertility, and probably in this patient there is no residual endometriosis we can see. So we will do controlled ovarian stimulation and IUI, not in the first cycle, because there is a risk of infection. So we do not do that um, in the immediate cycle, but in the subsequent 2-3 cycles we will do controlled ovarian stimulation and IUI. So that's it. Now it is time to remove the cyst, where we have made our one of the ports as 10 mm, and that same port we will be using for suturing also, which I described just a minute back. So here we are holding the tissue, and the cyst wall is removed. We do not use the Kellys to remove, because that increases the chance of causing a scar endometriosis. So either you remove it through the port, or you remove it in bag. The best is, and we never do colpotomy as a rule, because not in endometriosis patient, and in endometriosis patient, as it is, the pouch of Douglas is obliterated. So the options are these only. Now you can see beautiful The ovary is looking absolutely normal. These right, the left fimria, while we are getting ready with suturing, the dye has been pushed by the assistant sitting on the vaginal end, and we can see the dye has come in both the fallopian tubes. So you can see both the tubes are patent. This patient has a living issue, and her main complaint was not infertility. She has in fact two living issues, so we do not plan to do hysteroscopy. Otherwise, in all infertile patients we would do a hysteroscopy also. So now, as I said, I will just infold the ovary, and just close the raw area, and put a suture. And since we have not created an iatrogenic window in the ovary, probably this is the best technique for causing minimal damage to the ovary. And what we see, the test of our surgical skill or the surgical performance is the pregnancy. If your patients are getting pregnant, then probably the technique you have formed is a good one. Normally, in most of the patient, if there is some oozing, or I have a doubt of some collection, I usually put a drain for maybe 6 hours, so that any fluid or any residual collection or blood which is there in the pelvis is drained. And then after 6 hours or 12 hours, I would remove that. I do a thorough washing at the end of the procedure, and then leave some amount of saline in the pelvis, so that it is a good idea to leave around 2 liters of saline, which I was doing initially, but now I'm not doing. But I'm placing a drain, so that I let the all the fluid which is there collected, any blood clots would come out through that drain, and the pelvis would be clean. These all things, you develop as you keep on doing surgery. So you form your own techniques, and then of course the result is a good pregnancy outcome of your patient. So now you can see the ovary is brought together, and the all ovary is almost reconstructed in this particular case. The Whenever you have to give, suppose you are not able to lift out the ovary and you have to give an incision on the ovary, it is the best idea to give it as far away from the fimbria, so that the fimbria do not get stuck to your incision in the ovary. So here you can see, now we have brought together. We are not taking the surface or thing, but the only thing is we are just reconstructing. Of course, you are not going to get the ovary just like normal, because this is endometriosis, but this is a relatively good ovary where all the raw cervices are enfolded, and probably, if it gets stuck, it will go back in its position where it was, and the fibria will remain free. So the purpose of doing this kind of thing, I think it is worthwhile. It does take a minute extra, especially for the new surgeons, but it's worthwhile. So the whole of the ovary is reconstructed. There is a yes. You may not take very meticulous this, but even if you are able to take 2 to 3 sutures to put the ovary back, it is really worthwhile. So I do not use the V-lock suture here, because V-lock suture, because of the serrations, again the purpose is defeated if you are putting a V-lock and some serrations are pointing outwards, then the gut, then the ovary might get stuck to the ovary, to the gut, which is not the purpose. So now we get the needle out. It's always good to leave a little bit of length of the thread with the needle, because that makes the needle pull out from the pelvis easier. So now you can see the ovary is well constructed. You can see both the ovaries, the pelvis is clean, the tubo-ovarian relationship is maintained, and yes, I'm very happy with the surgery I have done, and I hope there is a pregnancy. Now this is with the end of the surgery. We are doing the port closure. Any port which is lateral and it is 10 millimeters or more needs a closure, and in the central ports, any port which is more than 12 millimeters or more needs a closure. So I have seen in the lateral port also a hernia. So if you are doing so much, must do a meticulous closure of the side port which is done. We also do closure of the midline port, but sometimes if you have gone above umbilicus, it's not possible. That's it. Thanks.